So basically a high syntax score, and what do we do under this kind of setting? That's going to be the question. So I bring to you compliments from my city of Pune, and we know that syntax score is based on angiogram, and these are the criteria which we use for scoring, whether it's left main is involved, whether it's total occlusion, bifurcation, calcification, and so on. And it doesn't take too much time if you're using your iPad to calculate the syntax score from the angiogram. So you just feed the data to the machine and you would get the result. Why we talk about syntax score today? Because the syntax study highlighted the fact that for multivessel disease, the PCI could be a good option, could work as well as the bypass surgery. And when we talk of revascularizing a case, just as we talk of stent thrombosis, which can give you an incidence of around 3.3, we also have a graft occlusion rate at the end of 1 year, which could be around 3.4. So there is a loss on either side. So it's a question of revascularizing a case from whichever. So we have a case here, and we have some panelists too, and maybe we could give them a mic so that they could contribute. So this is a 75-year-old, 49 kilos, obviously low weight. He presented an ACS, TROP is positive, ejection fraction 35% with a major inferior wall hypokinesia. The syntax score, as I will show you from the angiogram, is clearly about 30 or 33, which puts him into a high syntax score category. So there are 2 points in this case. One is age, which is 75, and weight, which is generally pretty low for sort of on either side. So the surgeons also can have an issue. So when you see an angiogram, you find that the RCA is occluded. This appears to be a recent occlusion, and that's the reason for his ACS. It matched with the ECE changes in the inferior wall as well as the echo observations that the inferior wall was grossly hypokinetic. Mind you, the wall is not thinned out, so it's just an ACS kind of situation, and LV could be salvageable at this stage. And this is the left side. You can see critical left main. You can see OM, which is big vessel, which is critically diseased, and some disease in the LAD. I'll show you the LAO-caudal view, and you can convince yourself that this is a significant left main stenosis, which is extending both into the proximal portion of the LAD as well as the circumflex. I don't know how many of you really appreciate, but there was a sizable calcium in the LAD, so that again takes the syntax score clearly up. So you have long segment disease. You have long segment disease in the LAD, but the distal vessel where the surgeon can possibly graft the vessel is clearly a good diameter vessel. So here we have to actually go back and think what can be done for this case. As I told you, elderly patient, ejection fraction not too bad, but recent ACS, TROP2 positive. One of the reasons why the surgeon is actually refusing to do this case is probably a recent positivity, though many people would take this kind of case. So the options could be the presentation is about 3 days old. Just wait and take the patient for surgery after a little time. Or if you are worried about the ACS coming from the right coronary, you can fix the right with a PCI and send him for surgery at a later date for the left-sided lesions. Or do a PCI total. So, can we have any comments?
Any comments from the audience? Sandeep?
Maybe we should get a mic here on the table.
Excuse me, can you give a mic to the audience, please?
Or maybe you can give your opinion in the meantime.
I think keeping the anatomy point of view, the surgery is the best. Even though his acute coronary syndrome trough positive, we didn't have any acute transeptal MI either in terms of your ECG or clinical features. Only thing is his age and his weight is 40 kilograms. That is the one thing surgeons may little bit apprehensive about, the low body weight in an elderly patient. And so, keeping total revascularization surgery may be the best option when compared to PCI. Where PCI you need multiple stents, keeping in view of two OMs, LAD, distal left main, RCA again, long segment disease, 2 lesions in RCA. So these are the sort of think in terms of financial constraints and also.
But let's keep the finance aside for the time being. Let's just talk of clinical indication.
From a technical point of view, bypass surgery should always be the first possibility. There's you said Syntex score is 38, so obviously you cannot ignore that hard number. Another point from a technical point of view, this is not infarcted, not ongoing chest pain. You can definitely let the patient cool down a bit. This right coronary also is having a collaterals from the left. So, as the time passes, his collaterals will grow. So maybe later on, graft to, if the surgeons take the case, graft to LAD diagonal, these two OM, then maybe to distal RC or PD. If surgeons refuse, obviously the first choice goes to the surgeon. If the surgeons refuse, then it's going to be a multi-vessel stenting and not less than 5-6 stents on the cards for these patients. And most likely it has to be a staged PCI in this patient under 1 or 2 sittings.
So how much should be the gap between the presentation and the surgery?
It all depends. I mean, you said that the patient is not having any gross ECG changes in terms of ongoing chest pain. So I presumed it's more like a ACS, not like an acute MI.
ACS, which is settling down.
Which is settling down. Generally, surgeons, they do take up these patients. They don't delay on this basis. They are only more scared if it's massive infarct which has occurred. Generally, then they at least want 30 days to settle down. But not in this scenario. This is more like an unstable angina or a ACS, where they will not refuse for a long.
So, TROP2 positive, your surgeon would be happy taking it on the 3rd day. Surgeons will look at, I think it's a reasonable targets, good sized vessels. So I guess this should be a surgical case. Anybody wants to voice a different opinion, or can we have a mic for you?
Just as a comment, one of the important things in multivessel disease to decide surgery versus PCI is presence or absence of diabetes.
Presence of
Diabetes.
Diabetes. No.
If this guy is a diabetic, I presume he's not.
No.
If he is a diabetic, then
We lean more towards surgery. As it is, we are leaning towards surgeons. Diabetes will push it further.
The second point is left main disease is necessarily not critical.
Not critical? Oh, I thought it was critical.
Unless you do an IVIS and demonstrate more bulk than what we can
I think
see
he's
in the
not
graph.
seen the earlier caudal shot. If you show him the earlier
Yeah.
caudal.
See, this is I'm showing.
That's foreshortened there. Little bit. So you could potentially do,
Anybody supporting, I don't know your name, doctor.
Dr. Adiraju.
Anybody supporting that left main is not critical? I think everybody feels left main
Yeah.
is critical.
So, I mean, in the sense that you could angioplasty this. So if he is not a diabetic, multivessel angioplasty is a...
So if
great
left main is not
better.
critical, you would like to do an angioplasty?
Yes.
How would you define criticality of this left knee?
I think you should do IVIS to really confirm that.
I think I
Because
was
if it's an eccentric plaque, it will look critical in one area, one view, in the other view it looks moderate, then you have to question the criticality, unless you do an IVIS.
I would feel that if you're talking more of PCI, I would do an FFR, which is
Right.
for left main still a good option. IVIS under this setting, I think would clearly show that left main is, IVIS always shows more. So,
No, I mean, if this is like a thread of a left main, then there's no question, you can't do angioplasty safely. This is not a left main that you can not think about angioplasty.
You know, the left main indications even for surgery are with left main disease of 50%, and we know the IVIS criteria. And this is not just a light left main, I would put it as a sinister left main.
Yeah, but that 50% left main for surgery is a changing recommendation anymore. That's the older recommendation. Well, I think I'm presenting next, I'll show you a case.
all right, so they say in my dictionary there is no S, which means no sleep and no surgery. So this patient, we talked to him, and I personally felt that that weight of 49 kilos is a very bad omen, and surgical risk would be clearly high. So this fellow, we ended up with 7 stents. Let's see how we do it. So this is an image on which we are working. We need to revascularize. We have to remember how much time I have. Is that correct? 13 minutes more? Okay. So we are
10 minutes now.
Okay, we have to revascularize the OM. We have to handle the bifurcation, and we have to handle the LAD. So our first guide catheter was 7 French. This is how we have gone. We stented the OM first, then came back to LAD, did a rota on LAD. I think we did rota first, then stented this one, then number 2 stents, number 3 stents in LAD, 4th here, did balloon here, and then put a left main to LAD as our 5th stent. The sequence, thus you need to plan how you would achieve all this. So this is a case where we start with rota to LAD. So mind you, you don't want 2 wires when we are doing rota, so rota first to LAD. Then we handle the non-compliant 3.0 NC at the ostium of the circumflex. This is a non-compliant 2.015 into the OM. So we stent this particular OM branch. So this OM looks good, it's a big size vessel. So now we come to the LAD, so the mid LAD is getting the stent. The second stent coming back to the proximal LAD. Mind you, this stent is not covering the ostium of LAD because we want single stent to come from left main into LAD, and then we have to do a kiss to the circumflex stent. So we have put 2 stents here. We are sort of sizing the left main. So when you have a nice angle like this is almost a right angle. Many times we use this T technique, or what is called as a flower and petal technique. That means you'll put a stent from circumflex ostium into circumflex. At that time, you keep a balloon here. Remove everything from circumflex, inflate this balloon in the LAD so that whatever little is projecting into the left main sort of flattens out into the left main. So circumflex stent, which is like a cylinder, the top would be sort of flattened out, and then you come in with a stent into the left main. So this is what we have done. Stent the ostium of the circumflex. We have a balloon left main to LAD at this time. You deploy the stent. First, let the stent in circumflex go up. Don't inflate the left main LAD balloon. So once you deploy the stent like this, you can see the stent looks reasonably good. You pull out the wire in the circumflex, inflate the balloon, and then you bring this regular stent. And then you reintroduce the wire into circumflex, and then you come up with a final kiss. So this is the final result. As you saw, 5 stents in the left main LAD and circumflex OM system. I'm not trying to say that we did anything great, but all that we are saying, the sequence in which the thought process has gone, LAD rotor first, stent OM first, then back to LAD, back to circumflex ostium, and then build up the bifurcation at the left main ostium. So this looks a good result. And then of course the culprit. So this is a little bit contrary that we are addressing the culprit vessel after we address the left main, but stands to reason that this was an already occluded vessel, some collaterals coming from the left system. In case if there was some goof off on the left side, we were keeping surgery as a possible option. So right was a fairly simple balloon stent kind of strategy, 2 stents in the right system. So the 7th stent in, and this is the right coronary, which is not a big circulation. So overall, a high syntax score going for this kind of procedure, not by choice, but I was equally worried about the surgical results in some cases. Many surgeons would object to the weight as a component, but in my feeling, healing is a big problem under these settings. Just to take a little high syntax score issue further, so whenever we're talking of left main stenosis, IVUS, FFR, OCT, OCT is a poor option for left main. IVUS, FFR can both be used as a good options for left main. So here's a case where we have left main distality, and IVUS actually tells us that the LAD ostium as well as the circumflex ostium are clean, there is no disease. So we end up putting stent exactly between the distality of the bifurcation back into the left main. So the stents actually starts and stops here with circumflex and LAD ostia not stented. Look at another situation similar in nature, lesion just at the bifurcation, we do IVUS. And IVUS, both at LAD and circumflex show that there is a disease, especially going towards the LAD. So in this case, in contrast with the previous study, we put our stent from left main into LAD, and this is actually a nice angle between the LAD and circumflex. Most of the time, when the angle is wide, there is a good chance that nothing will happen to the ostium of the circumflex. So after stenting, we have a fully open circumflex. We had not even wired this vessel when we were addressing left main to LAD. So you do not touch the ostium, and we just leave it as it is. So when you have a stent going like this, and the other vessel, the side branch vessel, is on the outer curve of the stent, most of the time the stent will not hurt the side branch, and you would find that the side branch continues to function very well, as in this case a big side branch, but we did not wire, did not have to address. Coming to left main assessment, this was an inferior MI, and right was disease. I don't have the pictures here, but this was the concern on left main. Many other views actually do not show significant left main, but this was one view which showed some disease. You can see the diameter of the left main is probably as big as the LAD, ramus, or the circumflex. So it's not a big diameter vessel, which could again mean that this could be a tubular narrowing of the left main right from osseum up to bifurcation. The important issue here was when we did an IFR, consistently it was around 0.63 or 0.65, indicating that the left main was critical disease. So we had a sort of a trifurcation issue on this. In addition, right disease. So this gentleman, purely based on the assessment of IVUS, based on FFR, went for a surgery to this issue. This was a LAD which was critical. Right also looked significant, but this looked borderline. Again, FFR on this as well as the right was very significant, so he underwent triple stenting, like in this same case, and we addressed all three at one particular go. I don't know if you're able to see it clearly, but a critical disease at the LAD osseum, the ramus osseum, which was a big vessel you can see here. So this gentleman actually had 3 stents, first going from left main to circumflex, second from here to inside, and third from here to inside. Similarly, CTO and LAD with a large diagonal and disease in this area. So our sequence is very typical in my lab. We first put the circumflex stent, then we put a stent from left main to diagonal, which was already a 38 line stent, and then from osseum, this is actually left main to diagonal through LAD, and then we are covering another 34 line stent from this point onwards to LAD. So the sequence is this one first, this one second, and this one third, ending with result. All patients doing more than 1 year clinical follow-up, extremely doing well. Thank you indeed. So we're trying to sort of sum up, saying that under complex high syntax score, true angioplasty can work. I'm not trying to suggest that you do an angioplasty, but under circumstances where you feel it's necessary, you can make it work. Thank you.
What was the platelet regimen used for that first patient, 7-stented patient?
Pardon?
Anti-platelet regimen, what did you use?
So they are all either on Prasugrel or...
He is 75 years old and not concerned with any bleeding.
which one? That first one?
patient.
No, that one was on Brilinta for 1 month. But at the end of 1 month, many of these I changed to clopidogrel aspirin, because I had patients who have come with subdural 1 year on Prasugrel. I've had people bleed, like coronaries-wise, we are doing very well. Our 6 month stress test is normal, but as a habit, we had continued them on whatever they were taking. I feel it's too much cover, dual antiplatelet cover, probably for lesions which are not necessary. So I switch many of them at the end of 3 months or 6 months onto clopidogrel aspirin.
Did you look for aggregability before putting the patient on Prasugrel? Platelet aggregability testing you do routinely do? No. For both Prasugrel and Brilinta, I don't think we need antiplatelet studies. It's only if you're going to take clopidogrel under adverse sitting like this, you must make sure that the antiplatelet cover is going to work, and under these settings, I would definitely do studies of this nature. Any more questions?
Sirish, brilliant work. I mean, I'm hats off for brilliantly executed case, but if you come back to the index case, I have 2 issues. We're rotating down a tight left main, triple vessel disease, occluded RCA. I may differ in your thinking process that I probably would have liked to have an open RCA when I rotablate down the left main into the LAD. Because if I get slow flow down into the left system, the right system is already totally occluded, I'm in trouble. So
I
that's-
get your point, but at the same
Yeah.
time, right was never looking very big to me, you know?
Yeah, but as a matter of, presentation, I mean, it's something which at least I would have done, because I would have, when rotablating the left main, I would have liked to have a,
Yes, Anil says always go for acute vessel first and open the closed artery so that you have some flow going before you address the complexity.
and the second thing is that I disagree with you, because I don't think this is really the flower petal. The flower petal is a very enigmatic technique, and according to the authors, it should be an IVUS demonstrated flower petal. To me, this looked more like a step crush. But if you did anything different, then I would just like to know. Because as I understand, you put the left circumflex stent and you crushed it with the balloon, and now,
Actually, I don't think it's more of a T and not like a mini crush.
I mean, it's
All that we are trying to
it's shades
say-
of grey. You keep making it less and less, then it is a little T, a little crush, and you've used that with the balloon. But that doesn't make it a flower petal. The flower petal actually comes more from backlash of the Szabo, of the Szabo technique, to lift one and to make that into a petal. And it should be demonstrated with an IVUS. So, well, it was brilliantly done. The angle was very good, and you finished with the old T, the classic T. Even if that was to be done, I think the results speak for themselves.
Yeah, I think in T technique, we keep a cylinder in circumflex and we join another stent straight away on the left main and then end up with a kiss. Here, since we don't want to miss any ostium, maybe we keep a little bit more into left main, but remove the wire in the circumflex. That is what the flower technique requires.
So that crushes that little bit which is there.
So when you remove, you have a perfect cylinder which is projecting, and then you bring in a big size balloon from LAD to left main, inflate, so that whatever is projecting sort of gets sort of flattened out.
What actually Dr. Anil Dhall is trying to say, that it may not crush concentrically. It may crush more to one side, like a
side.
normal mini crush, rather than a typical flower and petal.
Thank you.
Thank you very much, Dr. Hiram.